Thank you very much for that lovely introduction. I often think when I get an introduction like that, it'd be great if my mom were on the Zoom call, and she is actually. So thanks, Mom, for being here. I also want to thank the Meadow family for including me. For about 2 decades, Bill and I would debate a lot of issues, and I think actually he might agree with me today. So that makes this even more exciting to start. So I'm going to argue why all newborns should not have their genome sequenced at birth. But let me just begin with my 2 objectives, which are to distinguishing between targeted genomic testing and genomic newborn screening, and then to distinguish between newborn screening using current technologies versus genomic newborn screening. So just to make sure that everybody who's here is on the same page, what do we mean by sequencing? And we can talk about the whole genome, which is about 3 billion base pairs. Or we can talk about the exome, which is just looking at the proteins. Or we can talk about next generation sequencing, also known as high throughput sequencing, which is really just a catch-all term used to describe a number of different modern sequencing technologies to basically look at all the DNA within us. With each method, you still have to, what we say, interrogate areas of interest, which takes resources and expertise. In fact, there's a great article by Dr. Marty who says, we can get the genome pretty cheap, down below $1,000, but the interpretation is still going to be quite expensive. It's not like an X-ray where the whole picture is in front of you. You have to go searching for different aspects through those 3 billion base pairs. So let me start, as I said, by looking at targeted genomic sequencing of ill newborns. And it really only goes back about a decade. So in 2011, researchers from the Medical College of Wisconsin reported on a 15-month-old infant who had symptoms that looked like Crohn's disease, but that's not typical of that age group, and so they thought it might be an immunodeficiency. But when they did sequencing, they actually realized that he did have a gene that was associated with Crohn's disease, and the treatment would be bone marrow transplant. They did a bone marrow transplant, and the article ends with the child now eating and drinking. It's only a decade for the first time that sequencing actually changed clinical management. Fast forward a decade, and you have an article in the New England Journal last year by Dr. Kingsmore and colleagues out in California. And if you look at the picture, you can see that on day of life 41, the child presents. He actually presents with inconsolability, irritability, similar to a brother who had died 10 years earlier. But what you're going to see is by day 5, he's discharged home without seizures and thriving. And basically, it was found to be a thiamine metabolism. So his treatment is really quite simple. Some vitamins, thiamine and biotin, as well as some phenobarb, and he's home and thriving. So even when we can't figure out the diagnosis, genome sequencing helps because it sometimes gives us information of what things aren't, which can also change medical management. So again, another very recent article looking at 24 patients and looking at 41 changes of management due to genome sequencing. So genome sequencing in an ill child looking for particular explanations makes total sense. So I am totally in support of proceeding with sequencing, but I'm going to say, but proceed with caution. And here's why. An article that came out just last month by Callahan and colleagues was a national survey of neonatologists. It was hypothetical cases, but it looked at variants of unknown significance versus someone who didn't have that genetic finding, someone who had a genetic diagnosis that would affect neurodevelopment, but not actual survival, a genetic versus non-genetic etiology of equally severe pathology, and then a case where there was pending genetic test results. And what they found that the versions that included the variant of unknown significance, the one that had a diagnosis foreshadowing neurodevelopmental impairment, or a genetic etiology of a disease were all associated with an increased likelihood of recommendation palliative rather than intensive care. And so they concluded that the findings from this study suggest that neonatologists apply uncertain genetic findings or those that herald neurodevelopmental disability in problematic discriminatory ways. So proceed with sequencing, but proceed with caution. That's targeted. What we're debating today is about universal screening of newborns. And so I want to start that newborn screening begins actually in the early 1960s when Bob Guthrie developed both the bacterial inhibition assay to identify PKU and the filter paper on which to collect the blood. And it wouldn't be for another 5 or 6 years before the criteria for justifying a mass screening program would be developed by Wilson and Youngner and presented to the World Health Organization. And these 10 principles still are used today, and although not specifically designed for newborn screening, are clearly used in this community. Public health departments perform newborn screening, and they view newborn screening not merely as a test, but actually as a screening program. And they want to talk about not just the test, but getting to diagnosis, to getting to treatment, and to long-term follow-up. So some of these criteria are that newborn screening should include conditions that have a high benefit to risk ratio. They must be serious conditions presenting in childhood. There must be facilities to make accurate diagnosis, distinguishing between those who will and will not become symptomatic. There needs to be effective, accessible treatment and long-term follow-up. And one of the reasons it's so important that it's in the public health departments is because of the mantra that they need to help reduce disparities. So newborn screening expands over the next 30 years quite slowly, and part is because for every new condition we want to screen for, we needed a new test, until the development of tandem mass spectrometry, which allows us to have one sample that can test for many different conditions. And because of that, different states adopting it, we ended up in the mid-1990s with Michigan testing for over 40 conditions and West Virginia only testing for 4. And there were cries of geographic disparities, which led actually to the American College of Medical Genetics and Genomics and HRSA developing what's called the Recommended Uniform Screening Panel, or the RUSP. At that, originally there were 29 conditions and 25 secondary conditions. More recently, it's been increased to 35 core conditions and 26 secondary conditions. All of these are genetic conditions, most of these being diagnosed by metabolic, not using genetics. And the big pro is it reduced disparities based on geography by having a uniform panel, although some states still test for conditions outside of the RUSP, and not all states have fully implemented the complete RUSP. One test that was added in 2010 was severe combined immunodeficiency. And this is a great story because in California, when it was first done, pre-2010 and pre-implementing SCID testing into newborn screening, basically all the children who were being treated for SCID were of European ancestry. And data from the first 2 years of newborn screening for SCID found children of African and Asian ancestry and of Hispanic ethnicity much higher than was predicted by birth rates. And in fact, only 2 of the first 15 children to undergo bone marrow transplant because of the state newborn screening were non-Hispanic white. So again, an example of the real goal of newborn screening, which is to reduce disparities. So the question for today is, should we replace our traditional newborn screening with genomic newborn screening? And there are 2 ways to think about this. The first is to focus on the RUSP and what we already know has a high benefit. So only those conditions that we've already agreed we should be testing children. And the other is to do broader sequencing. So let's look at both options. First is sequencing the RUSP, and some researchers started in 2015, and they actually needed about 126 genes in order to get the 40 plus genetic disorders in order to be able to see if they could diagnose it. And for genetic disorders that are usually autosomal recessive, you sort of thought that there would be a genotype-phenotype correlation, that once you knew the gene, you would actually see the disease. But what the researchers noted was, quote, our ability to pinpoint the clinical phenotype of an individual on the basis of genotype alone is still in its infancy. In our case, only 3/4 of disease cases were classified correctly without phenotype information. Then they were told what symptoms these children had, and they were still only able to get 32 of 34. Now, 32 of 34 might sound good, but you have to remember these are very rare diseases, and the point of newborn screening is not to miss any of these children, because that's the purpose of reducing disparities. So the alternative is not to focus on the RUSP, but to interrogate the whole genome. And in fact, in 2013, the American College of Medical Genomics and Genetics published recommendations that, hey, if you're going to interrogate the whole genome, you should also be searching, a mandatory search or interrogation for reporting what they called secondary findings. And by mandatory, at that point, they meant no consent was needed, and there should be no right to refuse the return of results. And they had developed initially a list of 56. It's now 73 genes that should be identified, and most of these are adult onset only conditions. The ACMG policy was meant to apply to both children and to adults, and there was a lot of negative feedback about secondary findings. about these adult-only onset being identified in pediatric samples. And in fact, the ACMG report came a month after a report written in conjunction, the AAP with the ACMG, that I was the lead author, in which we argue specifically against predictive genetic testing for adult onset conditions. The American Society of Human Genetics also got into the debate 2 years later, agreeing with us about not doing predictive genetic testing of adult onset, but also pointing out specifically about sequencing. When genome scale sequencing is performed, the ASHG finds it ethically acceptable for the lab to limit the analysis to the genes of clinical interest. Since the vast majority of the ACMG 73 are adult onset only, the mandatory hunt is not necessary for pediatric samples. In fact, in the context of newborn screening, the statement continued, interrogating the ACMG 73 could be seen as a misuse of resources and may exacerbate health disparities. And they recommended that parents should be allowed to decline. I would go a step further and argue that neither the parents nor the clinician should even be offered these results. And you can do that by masking part of the genome as you're testing for it. But would it be effective? So one of the questions that Naomi brought up, would it be clinically effective? And so there was a study just done last year by Wojcik and colleagues as part of the BabySeq, and I'm sure that Robert Green is going to talk more about BabySeq, where they were trying to look at comparing traditional newborn screening versus genomic newborn screening. And they said a condition was newborn screen positive if there were any abnormal results found indicating disease risk, and it was exome sequencing positive if the exome identified a monogenic disease risk or genetic diagnosis. And the result was most infants were newborn screen and exome sequencing negative, but only one was positive in both methodologies. So these methodologies are not equivalent. There were 9 infants who had newborn screening positive for the RUSP. 7 of these were determined to be false positive, but that meant that still 2 true positives that were missed by exome sequencing. I also have to say that there was no genetic explanation for the 8 children referred on the hearing screen. So again, the exome sequencing was not an added plus. Most importantly and most disturbing is that 15 infants were exome sequence positive and traditional newborn screening negative, but all of these represented risk of genetic conditions that are not included in newborn screening programs that are really based on adult onset conditions, where newborn screening is about identifying conditions for which early treatment can prevent morbidity and or mortality of the child. To identify conditions that present later in childhood is actually ethically undesirable, particularly because newborn screening is mandatory. And this way it takes away both the child's right to privacy from his parents, as well as the right not to know of things that will not present for years or decades to come. And this could be a real negative if it starts leading to mistrust and greater number of newborn screening refusals. Now, I know my 10 minutes is almost up, so I'm just going to say, I'm going to quickly just say that there are ethical arguments that I'll continue in the 5 minutes, but there are ethical arguments against interrogating for the ACMG 73. I've already talked that children have a right to privacy against their parents for conditions that don't present until adulthood. I also would mention that information that's not going to be relevant for years or decades. People both have a right not to know. The information may change over time because our sequencing ability and our understanding of genomics is really evolving. And so we can be creating unnecessary fears or inaccurate reassurances. Information may only be wanted if there are known effective treatments or preventions, but that's not necessarily the case for all the conditions being identified. And it could also reveal unwanted information. So just to conclude, clearly in support of targeted screening of ill newborns, but the sequencing of healthy infants, we have a really good system with tandem mass spec, hearing screening, pulse ox. I'm not willing to risk it to add genomic sequencing, which can't pick up all the diseases that we know currently have effective treatments and can really change the life course for these children. And I really fear that if we start adding something like genomic screening, that we may lead to greater mistrust and reduced uptake of our traditional newborn screening. Thank you very much.
Okay, shall I jump right in, Naomi?
Yes, please.
Okay, great. I'll share my screen. Well, thank you, Lainie. You probably won't be surprised to know that I agree with you on a number of things and disagree on a number of others. Most importantly, I think as we start off this part of the conversation, uh, I want to make a distinction between replacing current newborn screening and an adjunct of newborn sequencing. But first, I just want to say to Susan, Xander, and Shmood, thank you. And to everyone there, thank you for inviting me. And what an honor it is to speak at this event in honor of Bill Meadows. I did purchase his neonatal bioethics book before searching for quotes that I could use in the debate in clever ways to rebut Professor Ross. I didn't find any that were going to be gotcha quotes, but it was a wonderful book, and it was a pleasure to be able to feel closer to him in this event through that work. So I'm going to argue that newborn sequencing is not only inevitable, but well overdue. I will start off and just declare my support and disclosures, which you can see there. In my case, interaction with industry has definitely shaped my thoughts, because industry is just willing to be a little bit more nimble and a little bit more forward thinking in terms of what people want and how to get it to them. The premise that I'm starting for is really that our health system writ large is terribly dysfunctional. It is really a sick care system, not a healthcare system. It does not try to maintain health, with a few exceptions. It is, we are badly mismatched when it comes to creating alignments and incentives for preventive services. And if we're to really survive the escalating costs of healthcare and really make people live happier, longer, healthier lives, we're going to have to actually concentrate on prevention, not just treating people once they have diseases. And genomics is by far not the only way, of course, to seek out risk and work on prevention, but it's kind of the tip of the spear. And genomics is ripening in a way that we can expect multi-omics to ripen over the next few years: proteomics, transcriptomics, microbiome, wearables, and the whole big data precision medicine, which I know is sometimes a buzz term that's used in irritating ways, but is also really a plea to the future to try to create a healthcare system that values and focuses on maintaining health. This sequencing of newborns is really a subset of the general population screening debate, particularly around relatively rare conditions, where on the positive side, we can diagnose and possibly treat unsuspected genetic conditions, where we can determine risk, not necessarily diagnosis, but risk for surveillance and prevention, and simply to respond to the desires of the vast majority of people who, in every single one of hundreds, even thousands of surveys, have said that yes, they want to know about their genetic risk. This is not in question. People really do want to know. And for the most part, they want to know more about actionable things. 70 or 80% want to know that. But in every single one of these surveys, consistently 50, 60% also want to know about things that are not actionable. So if we value that autonomy and we value their preferences, we should value that. Against this, of course, is that often these are rare conditions with a low prior probability. So you really could identify individuals, or in our case, we're talking about babies, who are at risk, but who do not ultimately manifest the condition, the problem of penetrance. We don't have a great deal of solid data on the clinical utility and the cost effectiveness. We are gathering those data now. And we certainly have inadequate expertise in the medical workforce, such that when things are found, it's a bit of a scramble to often figure out exactly what to do with them. But we also have a tradition in genetic and medical genetics of, I think, unwarranted genetic exceptionalism and a slew of popular narratives that I believe are largely untrue. The conditions are too rare to really make much of an impact. That there's just too much genomic information for either patients or clinicians to handle. That the information is toxic. That there's a narrative of catastrophic psychological distress. That there's going to be all sorts of misinformation, misunderstanding, and mistakes made. That that there are grave existential threats to privacy and discrimination, and that the whole thing's not cost effective. And perhaps most damning of all, a perception that none of this is actionable. And really, the last 15 years of work that I've done has been dedicated to rebutting each and every one of these precepts. I don't believe in genetic exceptionalism. I don't believe that any of these concerns are actually true. Our group, we have a core group that focuses on the benefits, risks, and costs of genetic testing, particularly preventive genomics, in a larger penumbra of about 300 close collaborators that we work with regularly on our studies. And we've had a portfolio of studies that have looked at both healthy adults, incidental findings, secondary findings, sequencing in the military, sequencing in among people who elect sequencing, the impact of direct-to-consumer testing, and commercial things like Verily Project Baseline. We also helped design the return of results for the million-person All of Us research program. The bottom line, when you ask what can you find when you examine comprehensively the sequence of an apparently healthy human being, is pretty startling. Just look for a moment at the notion that 11 to 20% of people who are apparently healthy, not enriched for any genetic condition, are carrying a dominant or biallelic mutation for a Mendelian or single gene disease. 90% plus of these individuals are carrying one or more, up to 7 or 8 sometimes, recessive carrier variants that could affect their baby's health if matched with a similar allele from their partner. Greater than 80% of people are walking around with an atypical response to at least one category of medications. And easily over 50% of people are going to be in the very highest percentile of genetic risk for polygenic risk scores for heart disease, type 2 diabetes, atrial fibrillation, multiple sclerosis, and a host of other conditions, including common cancers. You cannot look at this information and say that the genomic information is not going to be important in the health of human beings. So really the question isn't whether this is useful. The question is, how do we manage it so that it can be useful, that it will be useful. So we've done a lot of work in adults, but I'm going to focus for today's debate on what we've done in the BabySeq project. And even hearkening back 20 years, this is 10 years ago, Francis Collin said, whether you like it or not, a complete sequencing of newborns is not far away. In fact, 20 years ago, people were talking about this. I'm a friend of Nobel Prize laureate Wally Gilbert. He was writing about it in the 1980s. If you ask audiences, do you expect this in the next 50 years? Everybody in the audience puts their hands up. I will say that we curated a list that leaned toward actionability, that does not include VUSs, and that does enrich for gene disease validity. I will say that we found 11% of these ostensibly healthy babies had unanticipated monogenic findings, and that when we circled back, a quarter of these had previously undiscovered features of the genetic disease. So this isn't DNA even as a risk prediction. This is DNA as a novel mechanism for the discovery of subclinical pathology. And in pushing back on the narrative of catastrophic psychological distress, our randomized clinical trial was able to demonstrate that, in fact, in these self-selected individuals, of course, there were literally no signal for depression, anxiety, self-blame, or disruption of parent-child bonding, neither in the ones that were randomized to sequencing versus no sequencing, or even in the subset of parents who learned that their baby was carrying a mutation for risk. There's only modest increases in healthcare spending. And here's the slide I really want you to think about. Right now, there are over 600 genetic conditions with some form of treatment. And the best states in the country are only testing for about 60. That example that Lainie gave of SCID, took something like 11 years to get from approval to, or from the clinical approval of the treatment to administration in the state mandated newborn screening program. The state mandated newborn screening program is simultaneously one of the greatest public health successes of our time, and it is simultaneously entirely outdated and completely unable to meet the challenge of the next 20 years. We have 4 gene-targeted therapies currently with 400 in development. And you really only need to look at this where you can see the conditions on the primary RUSP that are factored into each state and look at the treatable conditions to see why it is entirely untenable to sit back and pretend that our newborn screening system is adequate. So not only that, but we need to insert genomics into lifelong human beings' care at this point, not just in newborns, but in childhood, in the pharmacogenomics of every drug that children and adults are going to do, in preconception screening to avoid catastrophic genetic conditions in children, in young adulthood, in middle age, and in older age. So I'll stop there for now and turn back my time. I think it's time for a rebuttal. Thank you.
So thank you, Robert. Fascinating, because there is a lot I'll agree with. I'll agree that you know, genomics is going to be here. The question though we're talking about is whether it should be here in the newborn period. And I'm going to still insist that the answer is no. I actually want to look a little bit more closely at your BabySeq study and then review specifically the ethical arguments against searching for and returning adult onset only genomic findings. So when you talk about targeting children for pediatric diseases, totally on board. So the protocol, the original protocol, had 2 cohorts, healthy newborns and NICU infants. And one group would get the standard of care newborn screening plus collecting family history, and the other would get a modified standard of care plus whole exome sequencing. And at that time, you were looking at over 5,000 genes, and there would also be indication-based analysis for ill infants. The plan was to collect parental DNA to inform the infant's finding, not to look specifically for parent of origin of carrier status. And you also were collecting survey data to understand the psychosocial issues. And I'm going to say, I got it. They didn't seem to be distressed. But originally you didn't allow for the return of adult onset conditions. And you had 3 arguments in your original paper. One was that the standard of care was not to return adult onset conditions. There was concern that parents would consent to benefit themselves or other family members and wouldn't be focused on the best interest of the child. And there was concern that to limit information so as not to overwhelm families in the newborn period. Your IRB questioned your decision, but ultimately agreed to protect child future autonomy and to avoid unknown risks. And the FDA stated it would only grant you permission to do it if you agreed not to report back adult onset conditions. You originally sought to enroll 200 newborns from the Well Baby Nursery and 200 from the NICU. And after 22 months, approaching almost 4,000 families, only 268 families enrolled. Slightly more from the NICU than from the Well Baby Nursery. So you tell me that people want to know, but here, over 90% of parents refuse. You had one case where a parent of an infant male in the ICU consented to research and the infant died and was found to have BRCA2. Now, the parents had initially reported a negative family history, but the research team felt moral distress, and you went back and got permission from the IRB to reconsent. And then when the parents reconsented, got the results, and then mom realized that she had some distant family members with breast cancer. But again, one of the things we know about genetics is genotype doesn't equal phenotype, and with such a weak family history, it's not clear how much of an increased risk she had over any other woman in the general population. But you argued it was in the child's best interest to help family, and the concept of family benefit was sort of born. And you wrote, in research, it's perfectly acceptable to make a condition of participation in the study the willingness to receive all clinically relevant findings, even those unrelated to actionable adult onset only conditions. Actually, the return of results is not traditional. We've only been returning results in research for probably the last 15 years. And the ACMG statement, which argued for the support of this, was actually all focused on the clinical context. And they've made a recent comment in 2019, reiterating that everything they said about the ACMG 73 was about clinical genomic sequencing and did not apply in the research setting because of so many unknowns. But instead, you've made BabySeq now, the requirement is that if you want to participate in BabySeq, you have to agree to get your results reported back, which is actually more stringent because in the clinical setting, parents do have the right to refuse this information, and no court would require clinical genetic testing of a young child for a condition that does not present in childhood. So what are the arguments against the BabySeq analysis? First of all, I should say that the AAP-ACMG report and the ASHG were consistent. Do not return predictive genetic testing if it's not medically indicated to preserve the child's autonomy. The BabySeq misunderstands the ACMG policy of returning these results because it's being done in research, not in the clinical setting. This notion of family benefit, Wolfand and colleagues, and you were one of the colleagues, argued that expanding the benefit from the child's medical best interest to family benefit can be justified because it indirectly helps the child by diagnosing parents with risks, not necessarily disease, but just risks, that data do not show psychosocial harm, and that it would respect for parental values, something I value greatly. But here's why those arguments fail. Newborn screening has to focus on the child. Otherwise, it's treating the child as a means for the ends of others. You can go ahead and test all the adults you want with genomic sequencing. You don't have to use the child to be a canary in the coal mines. Interrogating the genome for secondary findings takes work. It's not clear who pays for it, particularly when it's not requested by providers nor consented for by parents. In the case of BabySeq, are we sure that the family benefits accrued? You report that the mom was given the results, but there was no follow-up whether she acted on the information, no follow-up whether she could afford to act on the information, and it's not actually known whether the gene signified an increased risk in this patient given the minimal family history. And I would then argue that even if you have not seen yet any psychosocial harm, you don't have full data. So at minimum, your data support making it voluntary, not mandatory, as you've changed your policy. Provider distress can be real, but that does not or should not trump the participant's interests or preferences. And you could avoid it by masking and doing other ways of doing the genomic sequencing that you don't have to get these results back. My real concern, though, is that newborn screening has always focused on the baby. It's mandatory, although parents do have the right to refuse. And if we start overwhelming them with all these other diseases that we can test for, even if we're not sure what it means and we're not sure we have treatments, that we can really lead to greater refusals. And that would be a real loss for the public health system. And other investigators have explored the role of sequencing in infants and have specifically chosen not to look for secondary findings. So doesn't explain why BabySeq had to be changed the way it did. The ethical arguments are really important. Now, when I say that you can mask, there may be some times where you actually have to look at the genes that have adult onset only. And people have pointed out that you could have biallelic BRCA2 and it could be Fanconi's anemia. Although even in that case, even though the child would have 2 BRCA mutations, those are not mutations known to actually cause adult breast cancer. So again, there's so much about genetics we don't know. So clearly, at best, we could argue for voluntary screening, but we can't argue for making this mandatory. Children really do have a right to privacy about things that aren't going to affect them in childhood. And so we really need to have a system where if we're going to do genomic sequencing, it really has to be targeted to conditions that only present in childhood, particularly because so many of these are not going to be relevant for years or decades. And our ability to understand is going to grow and our ability to sequence is going to improve, and we'd be better off testing them when they became an adult for those conditions and avoid the inaccuracy of screening them right now. And I do want to point out that we really also want to avoid unwanted information. There was a systematic review of genomic newborn screening done by Downey that was published last year in JAMA Network Open. And what she found was that genomic testing does not currently surpass traditional newborn screening in terms of sensitivity, specificity, or cost effectiveness. and therefore should not be considered as a replacement. Rather, you can consider it complementary or as an independent mode of accessing precision healthcare for individuals, but that's not what newborn screening is. It's a public health program that's for everybody to reduce disparities, not for those who could afford these additional tests. They also found concern because there is agreement that everyone wants the information, but they also want to get detailed consent. And we don't have enough people who are able to have the skills or ability or resources to do that consent. And the real danger of that is that you can cause harm by lowering uptake. When people just get frustrated and fed up that they don't understand, they may actually refuse both traditional as well as genomic newborn screening. Downey also argued for the need of separating then the offers of genomic newborn screening and traditional newborn screening to avoid jeopardizing the success and efficacy of traditional newborn screening. She also pointed out the opinions of one group of healthcare professionals who had been surveyed working in the field, and basically the healthcare professionals agreed informed consent is necessary. And that's going to add an increased cost of immeasurable amount, because really to get full disclosure of everything that you can actually identify in genomic newborn screening is beyond the ability of most of those in primary care taking care of infants in well baby nurseries and even in the NICU. So I'm going to conclude by saying sequencing of ill newborns is becoming more useful in making diagnoses that can impact decision-making and treatment. We need to ensure equitable access by increasing capacity and ensuring appropriate funding. Sequencing of healthy infants cannot successfully replace current sequencing, and providing parents with secondary findings from the child sequence violates our obligation to focus on the child's current medical best interest. If you want to diagnose parental risk, please do so. Perform sequencing on their samples. Their children don't have to be canaries in the coal mine. And I'll take disagreement with you. I do think that newborn screening is one of the most successful public health programs, and it is and should remain focused on identifying early onset conditions for which early treatment can prevent morbidity and mortality. That is the child's medical best interest. Thank you.
Thanks. I'll just I think I can take Naomi, right? 2 more minutes to.
Yeah, of course.
Yeah. Okay. So just want to point out again, there's a bit of a false argument here. I am in no way, shape, or form suggesting that newborn sequencing should replace current newborn screening. I really see them as 2 separate things. And I see newborn sequencing as being like cell phones. In the very early cell phones, there were people who were early adopters, who were proactive, and who were probably had resources enough to buy the more expensive early cell phones. But they, through that, the cell phones got better and better and less expensive and more ubiquitous. And now almost everybody has a cell phone. So that's one thing. Secondly, we really haven't addressed, except in my initial comments, this whole HRSA RUSP cycle, which is very thorough, but is completely inadequate to the identification and treatment of new rare diseases. So even if you said, okay, I want to double down on that system, there isn't funding for it, there isn't speed in it, there isn't flexibility and nimbleness. So a couple of just maybe clarifications. It really is something of a travesty that we are not recognizing how many people are walking around right now with actionable conditions. For example, in adults, in our Mass General Brigham Biobank, we discovered that over half of the people walking around with BRCA1, BRCA2, and a few other cancer heritability genes, which are almost universally recognized as life-saving to discover them, enhance surveillance, offer people prophylactic surgeries, did not know they were carrying it and had never been offered that. And half of those already met established NCCN criteria. So I kind of reject the notion that it's not valuable to identify a family in whom this is running. Now, if you identify that family through the choice of the adult, I think it's best. But if you identify that family through discovery of the BRCA1 and 2 in a child, you are not only giving that information, the gift of that information to that child for the rest of his or her life, you are alerting all the first-degree relatives and necessarily one of the parents that they're carrying a life-threatening actionable mutation. It just seems manifestly unethical not to do that when we can and when it can be done fairly easily. As to your point on people not wanting this, I would like to clarify that when you survey people, they do want newborn sequencing. When you actually walk into their room, as we did 24 hours after they just had a baby, they often don't want to talk to a research assistant about anything. But once you do get past that and they actually would talk to a research assistant, 2/3 of the people did in fact enroll in the study, despite actually this being a randomized clinical trial where half of them weren't even going to get a sequence. And even more to the point, a very, very well done engagement project of over 1,700 adults in the UK found that a vast majority strongly supported genome sequencing for their child. And even that if the children were going to be at greater risk for developing health conditions later in life, would you want to know before they developed it? And the parents would want to know. We give parents autonomy and control of all sorts of things in their babies' lives. There's no reason why we should exceptionalize this. I think I'll stop there and maybe leave time for some discussion and questions.